pros and cons of training in the UK. I will give you an overview of the shape of training in intensive care in the UK, and I hope we can share our experience to see if there's any learning point or any beneficial in terms of training in Iraq. I finished my medical school in Baghdad in 2001 with MBCHB. I did my Iqama Dawriya for 2 years, and then I came to the UK. I did a lot of training, and it was a kind of a hybrid training mixture between the old system and the new system. So I was kind of the guinea pig of the dual training in intensive care, because I was literally one of the first, well, I was in the first stake of dual training in intensive care in the UK. I did MSc in the University of Leicester as well in Anaesthesia, pain management and critical care, and I did have to do some few exams during my career to get into a consultant job. I did part of my training as well post-CCT in Canada, which was a very enriching experience, and I've been a consultant for about more than 3.5 years in Glenfield Hospital, which is part of the University Hospitals of Leicester. It's a tertiary cardiac centre, and it's pretty much the biggest ECMO centre in the UK. We do about 12 to 1,300 cardiac cases a year. We have a significantly large intensive care unit in terms of the UK sizes, so we have about 22 intensive care beds, and we're expanding to about 31 in the next year. We have a whole range of trainees from different backgrounds and different levels, and we do train a significant number of MTI trainees. In particular, we had a large influx from trainees from India and Egypt, and they provide a very good experience for them, because they have the advantage when they come to this country with some background from their own country, so pretty much hone their skills and fine-tune their knowledge and requirements to become a consultant in this country. So why ICM? I think I've already lost the battle to you, sir, because everyone's going to be a radiologist from now on. So I'm not going to convince you, but I can tell you why I decided to become an intensivist. When I finished medical school in 2001, I did my residency, and during medical school I always wanted to be a cardiologist, but when I practiced it was a very difficult time, as all you know, and I had a lot of problems with a lot of acutely unwell people, system failure, a lot of frustration with difficulty to manage these people, and that's what kind put me in that direction to become an intensivist. So when I came to this country, I did a foundation, and part of it was having a 4-month modules, and one of them was intensive care. And when I did that, I said, that's it, that's what I'm going to do. And then, unfortunately, I had to become an anaesthetist as well, because that's how the system used to be here. Yes, but no, actually now I would swap intensive care for anesthesia, so that wasn't good. I quite like it. It's good to have that kind of jewel of accreditation, because they're very different specialties and they're very similar as well. But intensive care is pretty much looking after the sickest group of patients in the hospital, so you need to have a wide range of skills and knowledge to be able to do that. You'd be able need to prognosticate, system management, diagnose, and ethics and end-of-life care, which is big problem or big deal of your job as a consultant. Why talked about ICM? ICM is pretty much a new specialty. It's developed over the last 30 years to a point where it needs separate training programs. So compared to other specialties like in surgery and medicine, it's pretty new specialty. And this was developed based on the number of critical beds requirements and the number of clinicians working these units. So the UK ICM Modernisation Agency program recognized that severely ill patients best looked after in congregated area by a multidisciplinary team that's led by a consultant in intensive care. So this started from a small beginnings in 1988, and now an estimated we have 2,000 consultants in intensive care in the UK. So just quick history of ICM in the UK. So the development of ICM came based on 2 basic patient needs. So the first one in the 1950s, you're aware of the polio epidemic, and when they found that segregating these patients who needs ventilation into a part of the hospital will improve the mortality quite significantly. And then in the 1960s, with the development of different surgical skills and the more need for post-operative care of these patients, these were the two basic needs that developed intensive care as a specialty. In the UK, there was an intensive care society which was formed in the 1970s, and that was formed by a group of doctors in the UK, but there was no formal training at that point. In 1988, the Joint Accreditation Committee for Training in Intensive Care was formed, which recommended a 2 years training post-primary specialty for accreditation. CCT was still not developed at this point. 1992, Intercollegiate Board for Training in Intensive Care Medicine developed, and that developed a training program that was incorporated into the specialty, parent specialty of anesthesia, medicine, or surgery. And in 1999, the recognition of the specialty of ICM was achieved, and a competency-based training program was developed. And this is one of the first UK training programs, which is the joint ICM training. The current training is based on the Intercollegiate Training Board in Intensive Care Medicine in 2010-2011, and its successor is the Faculty of Intensive Care Medicine. So intensive care medicine doesn't have a college at the moment, it's run by the faculty. So you have been possible to train in ICM since the launch of the joint CCT in 2001, and this was amended to the full CCT intensive care in 2011, with the first trainees coming in 2012, and that's when I started training in ACM. The faculty is what's the professional body responsible for training, assessment, practice, and professional development of both trainees and intensive care practitioners. So, like the rest of the specialty training, intensive care follows a spiral training program. So the training is based on certain concepts, basic principles, skills, attitudes, and behaviors. And you have to learn these on repeatedly different stages of training with expansion and further elicitation and trying of training. The outcome is such that you master these skills and you become independent in practice, with the post to give you the opportunity, the skills, the time, and the attitude and behavior to become a consultant in that specialty. So based on these needs for the spinal training, the training is split basically into core training and high training. And because intensive care medicine is a new specialty, the core training was based on career towards ICM in one of 4 core specialties, and these were acute care common stem, core anesthetic training, core medical training, and emergency core medical training. So if you're not aware of the UK system, what we're talking about all different ST levels. So the ST3 is usually what gets you into a registrar job. So in order to get into that job, you need to do what in the old days we used to call a senior house officer into one of these 4 specialties. And acute care common stem actually came with the modernization of medical career following foundation training, which gave the doctors a wide knowledge and skills required to do medical, intensive care or anesthetic jobs. In order to qualify for that, it's not just fulfilling the requirements of training, you have to have an entry exam. And the entry exam depends on the specialty you're going to choose at that point. So if you're doing anesthesia, you have to do your primary FRCA, which is quite a tough exam, it's 2 parts. If you're doing medicine, you have to do the MRCP, which is again 2 or 3 parts, so it's quite significant commitments. And in A&E there is a different range of exams that you have to sit at different points. So the high training is by competitive national interview. So I go on a regular basis to sit on the panels, usually West Midlands, so Birmingham arranged the whole national interview panel. You will have trainees applying from different backgrounds, from different parts of the country and coming for interview, and they can apply for national training numbers. So once they secure the national training number, they can proceed into single ICM, CCT, but if they have a parent specialty, they will have a dual training in CCT and anesthesia and ICM, or medicine and ICM. So if you talk about single ICM training, it will be 5 years. If you talk about dual ICM training, it will be 6 or 7 years. Very familiar slide now. So this is the entry at different steps in intensive care. So from the foundation year 2, you do the core training for 2 or 3 years, and then you go into ST3 for another 5 years. So stages of training are 3, stage 1, 2, 3. It's competency based, and the competencies are driven from the syllabus. And this syllabus is based on the patient's requirements, on the NHS need for certain doctors with certain skills to provide care for the patients. So it's quite a big document, but the core skills that are required are split into 12 domains for intensive care. It's quite detailed, it's available online, so I'm not going to go through it, but it's basically based on the needs to deal with acutely unwell patients, professional code of conduct, and a few other things. So stage 1 basic trainings, which is pretty much the end of your SHO, beginning of your registrar job, so it's ICM 1 to ST4. It's on average 4 years, it can be 5 years if you're doing a dual training, which requires a minimum training of 12 months in anesthesia medicine and ICM across 4 years of training. At the end of it, you will be eligible to sit the FFICM final. There is no FFICM primary because in order to sit the final, you should have passed one of the entry exams, which is the FRCA or the MRCP. The FFICM final is a very tough exam, I think, because I've done a few of the specialty exams, but this is a mixture between anesthesia with all the basic science and physics and physiology, and a lot of medical diagnostication as well. So it's a kind of a hybrid exam between physicians and anaesthetists. So there are 2 parts, FFICM MCQ, which you have a maximum of 6 attempts, will be 50 SBAs and 50 true-false questions. It will be valid for 3 years, and then after that, if you pass it, you will sit the SOE OSCE, which you have maximum 6 attempts. The OSCE consists of 37-minute station with 1 minute rest in between, and the SOE will consist of 4 14-minute station with 2 questions being asked in each station. So it's similar to the previous Viva, to the old Viva style in the FRCA. So stage 2 intermediate, which is runs at ST5-6, covers ICM training in a variety of special areas. And that's pretty much providing the specialist intensive care skills to the trainees. So the good thing about this training system, even if you're not going to work in a tertiary center in the future, you have to develop these skills, because when patients come to a district general hospital or tertiary hospital acutely unwell, they can't select the intensivist who's going to look after them. So they have to have the skill at least to stabilize and manage these cardiac patients, for example, or neurotrauma patient or pediatric patient, then transfer them to the tertiary center. And that's why you have, during that training, to sit 3 months of pediatric, neuro, and cardiac ICM, plus a specialty of your choice. And then you come at the stage 3, which is the higher, and this is pretty much your final year of training, which is ST7. If you're doing a single specialty intensive care, it could be ST8 or 9 if you're doing dual training. And at this stage, it's more kind of the high-level management and the administrative skills, which I'm sure my senior colleagues and consultants agree that they're quite important skill when you become a consultant. It puts a big part of your day-to-day job in line with the clinical management of patient. So upon completion of stage 3, the trainee will be recommended for their CCT, and they will become eligible to apply for consultant jobs. So if you look at the CCT in intensive care structured, it's flexible, it's competency based. And we all know that's pros and cons for this. We already discussed some of them, but the training curriculum changes all the time. And the same way that I've changed practicing medicine in the last few years, actually I've been more struggling as a faculty tutor to catch up with the requirements of training, because they keep changing the post. Every time you come to learn the curriculum, they just change it next month. So the standards of CCT are based on these 2 big organizations, which is the General Medical Council and the NHS Litigation Authority. So I think if you look in Iraq about building a curriculum and a syllabus, it should come from the needs of the population. And I think a big organization, so I don't know who's going to replace these 2 big organizations, maybe the Ministry of Health or someone should have that initiative to set up these standards and regulation, because without them you can't build up a syllabus or curriculum to provide homogeneous care for the population in Iraq. Progression of our trainees is based on portfolio, competencies-based assessment, and they usually have to follow the GMC standards of curricula. And these are done by different methods and ways, and these change over time. But as a general rule of thumb, most specialty use a paper form, which are the DOPS, CBDs, and they all have different meanings. I don't think there is enough time to go through them. But they're very easy to assemble in any specialty, and they can be used in different situations. All trainees have to have a case summaries, and they have to have a logbook summary, and they all have to use the e-portfolio for intensive care now. How are you going to provide that, or how are you going to police it? It's different ways. So there's the head of school in the UK who oversees the regional advisors. You're a TBD, Hanna, isn't it? So you have to tell me who's the trainees coming to me, what do I need to provide them, because especially for intensive care, actually at the moment I don't have 2 trainees with exactly the same background and same requirement. So they're already very different, very heterogeneous, which makes my job really hard. But as a faculty tutor, I have to provide and make sure there is an educational environment in my hospital, otherwise I will lose that flux of trainees. So if I don't provide that, I won't get trainees in the future, because they give you a poor feedback. So it's a two-way process. You have to train them as well as you expect their respect and good feedback, so you keep to get trainees. And ultimately the educational supervisor is the person who will oversee the training of any person in the UK during their career throughout their process. So they're not fixed to the job where they go. So as a faculty tutor, I stay in Glenfield. If I'm educational supervisor for a person, he keeps moving, but he comes and talks to me on a regular basis about his progression. Okay? All these resources available online, so they're on the Royal College website for the anaesthesia. They're available on the Faculty of Intensive Care Medicine, ficm.ac.uk. There are very, very few resources that they're only restricted to members or people who set the syllabus, but pretty much everything is available. I hope this sheds some light on the shape of training in intensive care, and I hope it will give you some helping points maybe to use for training in Iraq. I'm happy to have questions.
Any questions from the audience?
Samir, thank you for a very interesting talk.
Thank you.
Just a question, is there any role for MDT in intensive care?
Yes, we have regular MDT. So MDT is a mandatory requirement for intensive care, and the MDT involve medics and non-medics, because if I mentioned in my slide at the beginning, one of the, I'll show you here. Sorry, this is my email in case anyone wants to email me about any questions. The Modernization Agency program, they did audits and research, and they found that the patient who looked after by a multidisciplinary medical team led by intensivists, it's quite important improvement to their care and their mortality. So in our unit, actually, we have MDT with the physios, nurses, dietitians, and few different groups of practitioners who look after the patient twice a week. We have
you get the surgeons in the MDT as well.
The surgeons can come. So there is a surgical MDT. They come and discuss. We don't have a specific MDT with the surgeons because we discuss every case with them pretty much on a daily basis. But we have radiology MDTs, and we have a microbiology ward rounds and MDTs. So we have a microbiology ward round 3 times a week, and radiology MDT twice a week, and multidisciplinary MDTs twice a week. But in terms of surgeons, we discuss every day with them.
Any more questions? Okay, that brings us to the last talk. Thank you.
Thank you.